breast surgical oncologist at the AtlantiCare Cancer Care Institute and chief of women's oncology services with a very decorated background. Dr. Flannery completed her general surgery residency at the University of Medicine and Dentistry of New Jersey and her breast surgical oncology fellowship at the University of Pennsylvania. And her path to medicine was sparked at an early age. And we're going to get into a lot of important information this hour with Dr. Flannery, and it is my honor to welcome you.
Thank you. Thank you for having me.
It is a pleasure, and obviously this is a very important area of medicine. Let's start with your new role. For those listening, Dr. Flannery is new to AtlantiCare, but certainly not new to the discipline. What does it mean to you to step into the position as chief of women's oncology at AtlantiCare?
It's such a privilege to step into this role, first and foremost. We are all see each other as women, right? I'm a wife, I'm a mother, I'm my mother's child, I'm my father's child. And to me, even from the beginning, this role really spoke to me. As women, we tend to take care of a lot of things that happens in a household, take everybody's burden on our shoulders. And for me to really step into this role of women's oncology, it's really bringing all of us into the spotlight to put the focus on women, to say that women's cancer specifically is very important in our institution. It doesn't mean that I'm inventing a new field or doing new things necessarily. A lot of the services that are going to fall under this new umbrella really existed here, obviously for many years. But my role is to be able to sort of bring everything under the same umbrella and really make things as seamless as possible, getting all of the great care that we're able to give to our women in our field.
I want our listeners to know that Dr. Flannery will still be performing surgery while leading the program. Why is it important to you, Dr. Flannery, to stay in the operating room?
My goodness, that's where I decided, right? What really I chose, the reason I chose to go into this field is to really be able to tell my patients to say, after I step out of the operating room, I took care of your cancer. I took out your tumor and it is gone. For me, being a leader in the field was always something that I was interested in. I was naturally really attracted to that. But I am a surgeon, first and foremost. For me to be able to lead this group of phenomenal surgeons and physicians in general, I won't be able to do it unless I know what I'm really supposed to be about, and that's to be a surgeon.
The topic this hour on AtlantiCare Presents is the Women's Oncology Program at AtlantiCare, and we have the leader here with us this hour in what I promise will be a very wide-ranging, long-form interview discussion. You're also a mentor and mom of four. How has your life experience shaped the way that you show up for your patients?
When I see particularly my female patients, I almost see myself in them. I see my mom in them. Most of the patients will come in with family members. They'll talk about their children, and I immediately just connect with them. And I don't know, I think it has a lot to do with the fact that I'm a mom of four. Life is very chaotic, right? I step into my house. My kids don't care what I did for that day. It doesn't matter to them that I was in the operating room taking care of somebody's cancer. I'm their mom, they want to tell me about how their day went. And for our patients, it's the same way, right? The families, their children don't see them as, oh, my mom has cancer. They just, want to talk to them as their mom. And to me, that really gives me perspective to be able to connect to my patients.
Sidebar question, Dr. Flannery. I want to say I'm sure, but I shouldn't say it that way. I'll just pose it as a question. Do you often hear from folks that they get this news that they have cancer? Then you decide what is the best course of treatment. In some cases, you can do things like lumpectomies. Um, sometimes you have to do mastectomy. So it's it's very dynamic, I imagine, the conversation, because it's so personal, but yet the person wants to live. They want to live for themselves. They want to live for their husbands, children, and all of this. Very difficult conversations, aren't they?
They really are. You know, women feel that we're defined by our breasts, right? That's one of the things that really we think about when we think of a woman. And when you are told that you have breast cancer, you are completely personally offended by it. It's how can this be? My breast that defined me as a woman is now riddled with cancer. And it just scares people and shakes them to the core in such a way that's very different than if you have cancer somewhere else. No one wants to be told, hey, you have cancer, but to be told you have breast cancer as a woman, it really is very much of a personal thing, and that's why I think a lot of the patients get very scared, and they immediately just get into this protection mode and figuring out, you know what, take them all. A lot of my patients will walk in, and even before I start the conversation, they'll say, I just want to live. Take them all. Do what you need to do. And it's my job to tell them, actually, let's talk about all of your options.
Because you might not need to take it all.
Absolutely.
How do you decide? And I imagine this is a very tough decision at times, whether you could take just a part and then do reconstruction even, and of course, that would be a fantastic result, or having to take the entire breast.
It really depends on the type of tumor and how widespread it might be. Sometimes women will come in with a very large breast that takes up the most of the volume of the breast. And so for me to say that I'm going to take this lump out when it's really throughout the entire breast is not ideal. But if you have a localized cancer where you have a very small tumor that's only affecting, say, one part of the breast, doing a lumpectomy is a perfectly reasonable option that'll get you really the same outcomes as doing a mastectomy. Now, there's other things like radiation or the pill or sometimes chemotherapy that will need to follow. Again, based on what type of tumor that you have. This is why we say this has to be personalized.
Yeah.
No tumor is the same.
Is there a thing, Dr. Flannery, called margins? Like we know if we go annually for an appointment to check our skin, and the doctor may see something and they take it, but then they make sure they take it past a margin where they know it's clean so that it's not going to spread, this kind of thing. Is that language fit into this, where if you take something out and the margins around there is no cancer, that you feel comfortable that, like, there's no trace or anything, that, because wouldn't it be a terrible thing to get a little bit done to then later have a bigger problem?
Yes. So clean margins, I explain to patients, it's like, taking the cancer out and having a nice rim of healthy tissue around it that allows us to know that we're not leaving tumor behind. We know that if we leave tumor behind or the tumor is on a margin of the specimen that I take, the chance of what we call recurrence, chance of the breast cancer coming back down the line is much greater. And so obviously we want to do everything surgically to avoid that.
We're going to take a brief time out. It's 16 minutes past the hour. AtlantiCare presents Dr. Flannery. We're talking about the Women's Oncology program at AtlantiCare. We'll be back in just a few minutes. I think it just really just illustrates, Dr. Flannery, the true kind of person that you are, because I'd like to talk about the time you held, I'm sure it's more than one time, you held a patient's hand before surgery, and why do moments like this matter in your line of work?
It's every time, every patient that goes to sleep on my operating room table. The way I see it is this, it's very scary. The lights are in your face. You don't know what's going to happen. You don't know what I'm going to tell you after the fact. But I am the only one literally in that room that the patient has met before. They can't bring their family members in. And so to me, it's even to just tell them that I'm there, I met you and I'm going to walk you through this, step 1 through however many other steps that we need to do. I would think that if my mother was going under and going through surgery, that somebody else was there holding her hand as she was falling asleep.
Love that. Dr. Flannery, this, I cannot wait to hear your answer. And I know a lot of people listening, this is either relatable to them, anybody that's ever dealt with being diagnosed the first time you hear the news. I know there's a few of my friends listening right now that are dealing with cancer. They just found out. How do you approach your conversations with women who are newly diagnosed?
The first thing I tell them is take a deep breath. And that might sound a little cliche, but it really is what tell them. People walk in with so many fears in them into my office
Well, like
because
number one is I don't want to die.
I don't wanna die, right? Don't take me away from my family.
Yeah.
I gotta be here for my kids. That's what patients will say, and they'll say, "Whatever you tell me to do, take them all." That's what a lot of them say, and I'll tell them, "Take a deep breath. My job here, I'm gonna hold your hand from now, and we're gonna walk this together, and my job is to tell you all of your options, and you and I sit here and figure out what is the best option for you."
Dr. Flannery is the chief of women's oncology and breast surgery at AtlantiCare Cancer Care Institute. The topic this hour is women's oncology at AtlantiCare. So, what better person than the leader to talk about it? AtlantiCare has had strong women's cancer services for a number of years. What does your new leadership structure add to this?
It's not that I'm necessarily creating new services, but I see my role as making sure that all the great services that we're already providing are not kept in a silo. Cancer care is so important, but can be at times very fragmented, and that's where the patients get lost in the shuffle. I want my patients to know that they're getting the best care, state of the art, the real technologies, the new technologies that are developing, and I want them to know that they're getting that, but also being walked through and really walking with them with our navigation to know that they're not going to fall through the cracks.
Let's talk about the end-to-end experience. Walk through the experience, what it looks like for a patient in your program.
So it really can go from anywhere from screening all the way through diagnosis. That's really why we call this women's oncology. Women come through the program, let's say you feel a lump, you saw a gynecologist, they order some imaging and said, you ought to see a breast surgeon. There's something suspicious about this. So you walk in, meet them and, do an exam and follow through with some sort of imaging studies like a mammogram and an ultrasound. Sometimes I have to go further than that. And then depending on what it shows, it might lead to some sort of a small procedure to let us know what it is that, this lump is. Is it a cancer or is it just a non-cancerous tumor that some women can really have and we don't necessarily have to do surgery?
Would that be a biopsy?
That would be a biopsy. And some biopsies I do in the office, some biopsies the radiologist will do in their office. It all depends on the circumstance to get to the answer that we all need to know. Is this cancer?
In terms of women just in general, and break it down if you have to in different categories because you might have a familial history, heredity issues, my mom, my grandma, this kind of thing. But generally speaking, and break it down into categories if need be, how often should women be screened? And at what point in life should they start being screened?
So, without any risk factors, if you don't have any family members that have breast cancer, at a minimum, you need to start at age 40 and do a mammogram on an annual basis. So, once a year.
But of course, if your mom had breast cancer at age 32,
Then
you don't wait till 40.
you don't wait till 40. Typically, what we say is you start the mammogram 10 years before the youngest age of diagnosis in the family. So if your mom was diagnosed with breast cancer, say at 40, then their daughters really should be starting at 30. Now, having said that, I don't want to get too bogged down into it. Mammograms may not be as great of a study for women that are younger than 30. So if your mom unfortunately was diagnosed with breast cancer at 30, it doesn't mean that you start with a mammo at age 20 now. There may be other studies that you need to consider.
What's your philosophy as it relates to folks? I mean, we sometimes hear about famous people. Angelina Jolie, there was something in her family's history. She was proactive and she had a double mastectomy before she was ever diagnosed. Um, are you a fan of that? Or are you an opponent of that? What are your thoughts about that kind of circumstance?
Angelina Jolie really brought this whole idea of genetic testing
Yeah.
in the era of breast cancer really to the front and center. She is a really different breed because she was diagnosed with having a BRCA mutation. Sometimes we call it the BRCA gene. Her mother and I believe her maternal grandmother all died from ovarian cancer. And this gene is particularly something that can be linked with both breast and ovarian cancer. If you have this, BRCA gene, your lifetime risk of developing cancer, so developing cancer anytime in your life can be anywhere from 60 to 80%.
So in her case, she just accepted that it was extremely likely that down the road she would deal with it. She decided to take matters into her own hands at a time of her choosing.
Exactly. But
What do you think about that?
I think that's so impactful and powerful. She really took it upon herself. You took your matter into your own hands. This is your fate. I am not going to die. I am not going to get breast cancer. I'm going to take this into my own hands and change my fate. And that's what she did. But, fortunately, most women actually do not inherit this gene and are not at upwards of 80% of chance of developing breast cancer. And so what I do tell patients is you don't necessarily have to consider doing that huge of a surgery, remove both breasts. This is why it's such a personal decision depending on what type of cancer you have.
We are visiting with Dr. Flannery. We're talking about the Women's Oncology Program at AtlantiCare. What do you see, Dr. Flannery, as the biggest opportunities to improve how women experience cancer care?
I think to alleviate the fear that's out there, cancer in general is such a scary concept. But women typically, especially breast cancer, as I said earlier, it defines you as a woman. And so right away, it takes a breath away. To know it's not a singular cancer. Every person's cancer is different and to know that a tremendous amount of progress has been made on a daily basis and that we have so many options to be able to treat that cancer. That's really important for women to really know and walk through.
We are already at our halftime break that quick, just like that. But a lot more important content with Dr. Flannery coming up. This portion of the Hurley in the Morning program brought to us in part by AtlantiCare. AtlantiCare is the official and the exclusive hospital for the Hurley in the Morning program. And I'm very proud to say, personally, for the Harry Hurley family. And it is my honor this morning, this hour, to present Dr. Flannery, who is the chief of women's oncology and fellowship trained breast surgical oncologist. Dr. Flannery is discussing how she is bringing compassionate, leading edge care to women right here in South Jersey who are facing breast cancer. It's an inspiring conversation. If you missed any of it, please, when we upload the podcast, take a listen. And for more information about Dr. Flannery, visit atlanticare.org/Flannery. It's exactly 30 minutes past the hour. AtlantiCare presents Dr. Flannery, and Dr. Flannery is talking about women's oncology program at AtlantiCare. Dr. Flannery is the chief of women's oncology and breast surgery at the AtlantiCare Cancer Care Institute. This, I believe, is one of the most important things that you're going to talk about this hour because there are folks out there listening right now. Perhaps they're in despair. They're thinking there's no hope and almost resigned to the fact that they're going to meet their demise. Are there times where you have a case? I know we can't speak individually. We can generally speak um, HIPAA and all that, but generally speak, where someone had just very, very, downtrodden, you know, very depressed, very, negative towards what was happening, didn't think they had any chance, and yet had a great result.
I come across patients like that. Just recently I met someone and I don't even know honestly how she walked in my office. She came with this huge of a cancer that was really just coming through the skin. She had no imaging, no biopsies. I think she went to like a grocery store and somebody told them my name or something and literally just walked in. And I looked at her and I said, "My God," I didn't tell her at the time, but I thought to myself, how could it have gotten this far in this day and age? And
Did she feel no hope?
she was petrified isn't the word. That's why I'm so curious as to what made her actually walk in to see me. And even I was trying to talk her through some of the things like I needed to do a biopsy, right? To know what it is, what type of tumor this is, what is it like to respond to. And it took a little bit of an effort for me to really convince her. I think by visit 2 maybe, or even the 3rd visit is finally when I was able to convince her. So she did that. It ended up that she needed, obviously, some sort of additional therapies, and she needed particular chemotherapy. And, even if you're not petrified, okay, even if you don't have a big cancer, if somebody tells you you need to have chemo, it really scares you to your core.
Yes.
And this woman who I don't even know how she brought herself to walk in, as petrified as she was, as desperate as she was, for me to tell her we really need to do chemotherapy, somehow I was able to convince her. I told her, you got to see a medical oncologist. We can do this together. And I'm really thankful that you bring this up because after all the chemotherapy that she did, I was able to take her through surgery. And when I got the pathology report, it had said that all of the tumor had completely melted away. So we see this as fibrosis. It's basically scar tissue from what was previously there that has melted away from chemotherapy. And now, I've done this for a while, right? I see all sorts of different tumors. Sometimes it really takes your breath away in a bad way, and then sometimes it takes your breath away in such an amazing way. And for me to see that report, I almost cried myself. I said, "My goodness, we really did it." And so, I was really able to give her a big hug to say we did it, together.
What a fantastic story. Dr. Flannery, I've had a philosophy as a layperson that you shouldn't be afraid to find out if something's wrong. You should be afraid not to find out that something's wrong. That's my theory. Men that don't go and have a colonoscopy, for example, or women that don't have exams when they should. Just ignoring it, it sounds corny, but that's not going to make it go away.
No, absolutely not. But, it's just the fear factor, right? The unknown. Like, what am I going to be told? Am I going to be told that I'm not going to live? The word cancer is just so scary that I think it's almost natural, human tendency to almost turn a blind eye for a little bit, be in denial. Maybe I don't
Yeah.
want to know.
I want to know, but early detection, almost in everything in life, but in cancer, early detection is so important, isn't it?
Absolutely. This is why we say mammogram really save lives. So let's talk about mammogram for a little bit. What does that really do? A lot of people say, is it extra radiation? I don't want that. Mammogram will find the cancer before the cancer becomes big enough for you and I to be able to feel it. We have data that tells us really cancer that's non-detectable. The clinical exam can only pick up about half of the cancers. This is why mammogram saves lives. It'll pick it up before it becomes big enough for us to really feel it.
I think this is a great question from a gentleman that I've known for basically my entire life, just about. And great person, public safety, retired, just great person. So this, I think, is a good question. It's certainly not one I can answer, but I know you can, Dr. Flannery. So this listener mentioned they missed a few minutes of the segment, apologizing if you've already covered this, but we did not cover this to the gentleman that's writing us. And he asked the question that because he heard us talking about or heard you talking about biopsy. He said regarding the biopsy, sometimes they do a needle biopsy. And is there a concern for when they draw the cells out during the needle biopsy that if there is cancer cells, some can leak into the body and basically spread the cancer? It's a good question.
It is an absolutely good question. And almost everybody will ask me that if they come to find me before they've already gone through a biopsy. But we actually have zero evidence that tells us that the cells spill out. In fact, it's actually standard of care for us to, if you feel something palpable or if there's something abnormal, needle biopsy is the first step to get the diagnosis. The reason is this. Let's say you have a cancer and there's a lump and I decide for whatever reason, and this is what used to happen. People just went straight to surgery to remove the cancer, then not to remove the cancer, but to remove the lump to find out what it is. If it is a cancer, you almost always have to come back for a second operation because you need to worry about lymph nodes, you need to worry about margins like we talked about. And so you really can't plan for your next step. And so this is why we need to do the needle biopsy, and we have no evidence to suggest that it's going to spread the cells around.
The next question, I think it's a really important one because a long time ago, if somebody got bad news about their heart, if they got bad news about cancer, they were filling up the car, driving at least 60 miles away, if not 120, if not to Cleveland Clinic and this kind of thing. But now with AtlantiCare and all the capabilities that we have, there are so many things happening right here where diagnosis happens here, treatment happens here, surgery, if necessary, happens here, post-op, everything. Like, in other words, you don't have to go somewhere where you're a stranger and feel sick if you're having chemo or any other type of thing and limp your way to some hotel room, in another state. I mean, I think it's so huge what AtlantiCare brings to South Jersey, as Southeastern New Jersey's largest employer at the same time. What are some of the challenges, in your estimation, Dr. Flannery, that women in this region, South Jersey region, face when it comes to getting the care that they need?
I think it's the notion that you may have to travel far, the transportation. But you bring up such a great point. When you go through, say, chemotherapy or surgery, it's not just that day. You have to come at a recurring basis. You may have side effects where you need to really return to, unpredictably, to the doctor's office. You really should not be traveling far. You're immunocompromised where you may be susceptible to catching bugs, for instance. And so it really is so important medically, to be safe, to be treated near where you live and also get the care as soon as possible. When it comes to cancer, the sooner you have the appropriate treatment, the better it is. We have so much data that tells us that. And for patients to think, I need to travel elsewhere, wait the time and delay my therapy, and then have to travel back and forth and maybe fall through the cracks. I think that notion is what really riddles the women around here. And really, this is why I came here. We're able to offer all the great things, all the top of the notch clinical trials that Cleveland Clinic offers right into our backyard.
We're going to come right back. It's our final break, final segment. Straight ahead, we're visiting with Dr. Flannery, who is the chief of women's oncology and breast surgery at AtlantiCare Cancer Care Institute. It's AtlantiCare presents Dr. K. Yoon-Flannery right here on the Hurley in the Morning program. We're keeping right on schedule here with Dr. Flannery. AtlantiCare presents. How are you thinking about expanding care in the community, not just inside the hospital walls? What are your thoughts, Dr. Flannery, about that?
My gosh, community partnerships are so important to me. I can't just treat, patients that I can't expect to treat anybody just inside the walls of the hospital. I got to get out there. I got to make sure that patients are enthusiastic about getting early care. As we said earlier, early detection saves lives. My job isn't just to treat cancer, honestly. I see my role as inspiring people to not be afraid and talk to their physicians. Ask questions, be your own advocate, and really be there and be present for yourself so that if there is something to be found out, we find it out early.
Dr. Flannery, I just thought about something. I want to go back and revisit a question because we talked about if there is a familial issue, and you mentioned about 10 years prior to the first person in the family that's had the breast cancer. That's sort of your baseline. That's the time you go for your first mammogram screening and whatnot. What if it's not in your family, or you just don't know? Even maybe it is and you don't even know it. If there's no heredity issue there, what should a woman do?
But still start mammogram at age 40.
Okay.
I will tell you this now that you brought it up. Actually, if we tested everybody with the breast cancer diagnosis, if I had to be very generous, only about 5% of those women actually have a genetic mutation. 90 to 95% of the patients that may have family history of breast cancer and all sorts of other cancers, we don't find anything from their genetic testing. And so it doesn't mean that we just rely upon our family history. We stay on top of it. That's why getting this early on is so important to find it at, starting at age 40.
And I know this from somebody very close to my wife and I, that you could do your mammogram screening last year and the report comes back, nothing remarkable. See you next year. You come back next year and there's a finding.
Right. And that's why we can't, people will say, but my mammo was normal. Well, how long was your mammo? 4 years ago. Well, so this is what I do though. I don't look backwards. I don't chastise patients
Like,
to
hey,
say, well, just skip it, right? You did this.
because you
Never.
of what you have now.
We have what we have now, what we know, and
And that's the last thing somebody wants to hear ever. And that, oh my God, you're telling me I'm the reason, look at this. I should have been doing something over the last 4 years. I'm here now. Doctor, what are you going to tell me now?
exactly. And women really tend to blame ourselves when something goes wrong. And so they already do that. I don't add to that. My job is to let's look forward. What is this and what are we going to do about it? What are our options?
And I say this not to sound corny or, really flattering towards women, but I really, really believe this. And I've said it behind your back. So I'm going to say it right to you, Dr. Flannery. I believe that women, and I know women can do everything. They can work full time. They can take care of, husbands and children and all of this. But women many times take care of themselves last
Yes.
and everybody else first. So actually letting something slide, oh, I mean to do that. And you know how life is. A year can turn into 2 years, into 3 years, into 4 years. And next thing you know, oh my gosh, look at my circumstance now. I should have been doing that then. But they were busy taking care of everybody else except themselves. I think, and I know it's coming from a man, I think that's a fair comment.
Not only that, I have so many patients after they've been diagnosed with breast cancer and I'm trying to set them up for surgery. They'll say, I can't do it that week. My son is getting married, or I got to move my daughter into college. So we got to do it, after that. Even after they're diagnosed with breast cancer, life doesn't stop for us, and so it's just that's why it was so important to me. And I'm very passionate about having this women's oncology, we have to put the focus, and even if against their wishes, we have to say, you know what, we're going to put the focus on you and take care of you.
See if this makes any sense. It sounds like it makes sense to me, but you're the expert. Once someone finds out they have their diagnosis, they have cancer, I believe sense of urgency is urgent because you never know. We know someone, I'm not going to out this person, but there's somebody that my wife and I know very, very well. And they found a cancer, a woman's cancer. This individual, same profile that you're talking about, taking care of all kinds of kids and all kinds of stuff. Just a very short while later, it had almost made its way entirely through the uterine wall in such a short period of time that if they actually let the surgery go any longer, it would have spread. Now, it can happen fast, is what I'm trying to say.
Absolutely. And so, actually, as a breast program that's accredited nationally, we have some benchmarks, that our organization said we absolutely want to treat women with breast cancer in less than 60 days of their diagnosis, meaning from the date of their biopsies. w- a lot of women actually who get treated, and if they have to drive far and elsewhere, you miss that mark. And to me, I take I mean, I'm very responsible, right, to my own patients to say, I don't wait till the 60 days or the 90 days. I want to take it out as soon as possible and schedule it.
Because while it's in you, nothing good's happening.
No, and
So you want to
man,
get it
that's
out.
crazy. Cancer cells, they can really add,
Apply fast, right?
multiply fast, and they can grow in an unpredictable pattern. You don't want to let it sit.
If you let too long go, what you thought you were dealing with now could be an entirely different case.
Absolutely. And it may become something where we can no longer cure. Early stage breast cancer is curable, absolutely, and that's where we want to get at that.
The whole hour has been public education to the max, but this really is a public education moment. Dr. Flannery, what's one thing you wish more people understood about breast cancer or women's cancers more broadly?
That we have made tremendous, tremendous amount of strides and advances. Hope is real. The cure is here, and we have so many options that it's not the end of your life or the world or your family, that we really have made a lot of advances and that it's real.
Remarkably, and I don't even know how it happened this fast, but we are to the 2-minute drill. So we have 2 minutes, and I think this is a very important dynamic question for you to take whatever time you need, and then a closing comment if you have a few seconds after that. When you think about the next chapter at AtlantiCare, what are you most hopeful?
That I'm able to create this amazing program, pull everybody together and say that not only are we giving state of the art, therapies to patients, but that we're doing it in a compassionate way. We want to look at every patient as a person and not as a number. And as a woman, as a wife, as a mom, it's so personal to me that I am able to bring this to our own community.
And what I'd like you to do, if you would, and we have exactly a minute, is a closing comment on women's oncology, breast cancer, anything you'd like to share in closing.
It's so important. Women are really the gatekeepers. We're the ones that take care of our families. And that's why it's so important that you know that all of the treatment options that are state of the art are available right in our backyard. And so please remember to take care of yourself. Don't put everybody else in front of you. And even if you do, we are here to take care of it with you.